Okay, so in this video, I'm going to specifically focus on Cryptococcus neoformans. This is a systemic mycosis that's caused by an encapsulated Basidiomycetes yeast. That's a lot of buzzwords, but essentially it's an encapsulated fungi. There are two actually cryptococcal species that we worry about, Cryptococcus neoformans and then Cryptococcus gotti or gottii. I'm not going to talk much about gotti. I'm just going to focus on neoformans, but you can kind of assume that they're going to cause similar syndromes. Okay, so let's go a little bit first more in depth on fungal infections of the brain. I have a whole separate video on fungal infections of the brain that you can watch. But essentially what we're worried about here, particularly with C. neoformans, is our immunosuppressed community, our HIV/AIDS community. Many of the fungi that we talk about actually spread to the brain via hematogenous spread because they're very angioinvasive. A great example of this is Aspergillus. It's the most common invasive mold in the world, and it has a very angioinvasive nature, which causes it to spread to the brain, leading to multiple abscesses, which you can see here in this brain here. All of these got here via the bloodstream, and all of them are caused by Aspergillus. Okay, but let's talk specifically about Cryptococcus neoformans. It's a yeast found in the soil throughout the world. It has been associated with pigeon guano and other bird species, but particularly pigeons. However, this association is kind of loose at best, but I think it's safe to say that you shouldn't play around with bird poop. And if you have a patient that seems to spend a lot of time with birds, then this is something that you might be concerned about. It's divided into 4 different serotypes that all cause disease, A through D. And so there are serology tests that you can use to kind of drill down which serology your patient has. It actually grows really well in culture at about 37 degrees, but it is going to take a couple of days. Remember, fungi are eukaryotic organisms. That makes them immensely more complex. They're going to take a little bit more time to grow. It's characterized by kind of this round yeast form surrounded by a large polysaccharide capsule, like you're seeing here. And then the other thing is it has narrow base budding. So this can differentiate it from like blastomyces, which has that broad-based budding. You get it via breathing. It's an aerosol transmission, likely while people are digging around in soil. And because we get it from inhalation, we often expect to see pulmonary signs first. So if you have an immunocompetent patient, they're likely to just be asymptomatic. But if you have a immunocompromised patient, so this is competent, if you have immunocompromised, then we start worrying about other things, particularly pneumonia is a big one, and then meningitis is the other one. And we're going to worry about both of these in, say, our HIV/AIDS community, where it's a significant opportunistic pathogen. The best way to find it is using India ink. It's an India ink stain of the CSF. In about 50% of cases, that's going to help you find it. You can also look for presence of antigen in the CSF and blood, but culture remains the gold standard. As I mentioned, it grows really, really well. So that's a great way to look for it. You can treat it really, really easily. High dose, long-term care, but you can use amphotericin or 5-FC. Both of these are good options. Fluconazole, all of those work well against neoformans or Cryptococci neoformans. But, you know, it's one of those you have to be able to identify it in order to treat it, and not everybody is always aware about it. As I mentioned on the last slide, most of the time Cryptococcus causes an asymptomatic infection, and we're able to clear it and it's no big deal. In some patients, it triggers this pulmonary infection when the yeast spores are inhaled. But the biggest danger that actually faces most patients is actually that the fungus can cause almost like a latent infection. And in this way, it's very similar to tuberculosis, right? Where it's in you and it's growing, but you're not really bothered by it until something happens that makes you immunocompromised later in life, either because you've gotten older and our immune system slows down as we get older, or because you've become HIV positive or are suffering from cancer or some sort of liver disease. So that's when we actually get more concerned. When we've got this latent infection in an extrapulmonary site, that's very dangerous. When this happens, the fungus kind of grows without any clinical symptoms, say in the brain. When the patient becomes immunocompromised, the fungus grows just kind of uncontrolled, okay? So I want you to think of it in the terms of an HIV positive patient, all right? So in the HIV positive community, we have to think about kind of the levels at which a patient becomes diagnosed with AIDS versus when a patient is just HIV positive. A patient becomes diagnosed with AIDS normally when their CD4 count falls below about 250. So at this point, this is very low. And at some point, you may even see patients with even lower, in the single to double digits. At that point, there's literally no regulation of the immune response. So the immune response can't function. There's no CD4s, so there's no help for the CD8s. So we're not able to clear things like this. So now the fungus is growing kind of uninhibited in the brain, okay? So at this point, your patient starts exhibiting symptoms. So headache, malaise, fever. Eventually, because it's in the brain, we'll start seeing nuchal rigidity, emesis, an altered mental state, so behavioral changes. This is referred to as kind of disseminated cryptococcus. So we've moved from from the pulmonary site to the brain, and now we've got meningitis-like symptoms caused by a fungus in the brain. So your patient comes in, one of the first things you do is run a CBC. You see their CD4s are like absolutely nothing and that they're HIV positive. So not only do you treat the cryptococcus, but you also start treating the HIV. Great, right? Now let's say our patient survives. You put them on therapy for their HIV and their CD4 count rises to above 1,000. Fantastic, right? Yes, but not really. Because in this case, all of these CD4s are going to immediately go to work. And they're going to flood the brain. The brain doesn't like to be flooded. So what that is called is immune reconstitution inflammatory syndrome, or IRIS. So essentially, you had no CD4s, so the fungus became a really big problem in the brain. You got the CD4s back, all the CD4s went to the brain to fix the problem. And that's called immune reconstitution inflammatory syndrome. It's when your CD4 response rebounds such that then you have a different problem. You have too much infection. This leads to something very similar to what we see in MS with JC virus, where you get progressive multifocal leukoencephalopathy, where you just get flooding of immune cells in. Cryptococcal CNS iris is often fatal, and these patients are often, even if they do survive, significantly altered as a result of this inflammatory process. And you get scarring, and it may require shunting just to relieve the pressure in the brain. When you look at it, you'll be able to see it pretty quickly. You'll have this leptomeningella infiltrate surrounding the medulla, and you can also diagnose the fungus using silver stains, but it is difficult to see on H&E. Treatment, as I mentioned, you're going to put the patient on amphotericin B or flucytosine, and this is going to be lifelong. You're pretty much always going to want to protect them from this if they're HIV positive and you know they have cryptococcus. You can't trust that they've ever gotten rid of it sufficiently.